Hello, my name is Dr. Ana Hernando, and I am presenting to you um, navigating ethical challenges in OT practice. I'm going to go ahead and start here. I have been an occupational therapist since 1998. I have a PhD in performance psychology, and my dissertation was on moral distress as described by occupational therapists. It is published in the ProQuest database. I want to welcome you to this course, Navigating Ethical Challenges in OT Practice, Aligning Your Values with Action. And I am so glad that you are joining me to explore how we can navigate ethical changes in our day-to-day OT practice. By the end of this hour, you will have a stronger understanding of the AOTA core values, how to apply ethical reasoning to clinical decisions, and how to document and act with integrity. We'll also spend time mentioning a couple of case scenarios and go over a little bit of what you can do there. Specifically, we're going to identify core values, understand the AOTA core values and ethical principles. Going to apply decision making. So we're going to use some strategies to resolve clinical dilemmas or reflect on those values, like examining your personal values and moral reasoning. Evaluate scenarios. Again, I'll analyze some case-based scenarios for a group discussion. This is recorded, so it's going to be more of my discussion. So there's no really group discussion in the recorded version. And then we'll review the standards of awareness of documentation and conduct standards and evaluate some of the scenarios. So I'll present, have a presentation and analysis of some case-based scenarios. So why does ethics matter in occupational therapy? Well, ethics are the bedrock of our profession. They guide us when we are unsure. They protect our clients and ultimately uphold the trust placed in us by our communities. When ethical practice breaks down, we risk harming not only individuals, but the entire field. Ethics help us improve outcomes. They help us get better client results. Again, it professionally protects us. We avoid sanctions and license loss. It looks at if we're acting ethically, we don't have to be concerned about doing harm. And again, it builds that safety and trust. It really develops that therapeutic relationship. Ethics impacts so many things in the profession. It impacts billing. Am I billing for what I say that I'm doing? Am I actually doing what I'm billing for? So not only am I billing what I'm doing for, but is that reflective? In other words, if I said that I'm doing ADLs, did I do ADLs? Or if I did the ADLs, did I actually bill the client for it? It impacts supervision. I know a lot of times in a lot of places, the rules of supervising occupational therapy assistants has changed. So what does that mean? And so with ethics, we have to make sure that we're knowing all of the upcoming changes or the changes that have happened and that we're holding our companies accountable to how those supervisions rules and regulations have changed. And ethics impacts service access. It's essential for maintaining professional standards. If we don't have professional standards, are we really a profession? There are 7 core values from AOTA. They help define our character as profession. They are altruism, which is we have concern for the welfare of others. Equality, which is fairness and impartiality. Am I treating all of my clients the same? In other words, if I have client A and I treat them with ADLs and I bill for ADLs, and then I have client B and I treat them for ADLs, but I do not bill for ADLs, That is not fair and impartial. I've changed as to why of how that billing. If I did the same type of treatment, I need to bill the same. And it goes into a little bit more. That was just one example. Freedom, respect for autonomy. We hear so many times that patients have rights. Are we respecting those rights? They have autonomy, and are we actually respecting that? Justice, inclusion, and moral integrity. Am I leaving certain types of people out of my treatment setting? Am I keeping treatment from people based on what have you, any of the any particular reason that I'm discriminating against anyone? Am I leaving people out on purpose? Dignity, value, and respect for uniqueness. Am I honoring the dignity of my clients? Am I respecting their perspective, their points of view, their values, their belief system? Truth. Am I working with in honesty and authenticity? Am I misrepresenting myself? Am I providing a treatment that I don't have the training or the confidence to provide? Am I recommending certain activities that I really don't know are evidence-based? It's important that we act with honesty and authenticity. And then prudence. Am I using sound judgment? Am I using good discretion when I'm working with my clients, when I'm talking about my clients with other peers so that I can get feedback? Am I using good discretion? So these 7 core values, they're not just concepts to memorize, but they're ideals to live by, shaping how we interact with clients, their families, and even each other, other disciplines. Now, there are 6 principles that form our ethical compass. And that compass is that radar that says, which way am I going? Am I deviating too far away? Am I in the gray? And how much in that gray am I? So these principles form our ethical compass so that we are always pointing due north. Beneficence, it's promoting well-being and positive outcomes for the client. Am I looking at what is going to be a positive outcome for them? Autonomy, respecting their choices, and ensure informed consent. There is a difference between informed consent and informed coercion. Informed consent is merely saying to the client, these are the things that we are going to do, or that the treatment that's recommended. These are the positive effects of that treatment. These are the negative effects of that treatment. And then you have the choice. This is what you can expect. And they consent. Yes, I agree with these, or no, I don't. Informed coercion is more along the lines of, if you don't sign this, you are going to be kicked out of here. If you don't sign this, this is what it's going to do to your family. This is the bill they're going to get. So autonomy means respecting their choices and ensuring informed consent. Veracity is to be truthful and accurate in all communications. Everything that we're saying, that it's truthful and accurate to the best of our knowledge. Non-maleficence is to do no harm in all therapeutic interactions. That's the one that everybody thinks of as the Hippocratic Oath, right? First, do no harm in my therapeutic interactions. Justice, provide fair and equitable access and treatment. Fidelity, honor commitments and respect relationships. So where benevolence urges us to promote good, and non-maleficent warns us to avoid harm, Autonomy means respecting our clients' choices, even when they differ from our own opinions. The principles often overlap and sometimes compete in real life. Ethical decision-making is a process, not a reflex. So first, we need to recognize the issue, identify the ethical dilemma. Then we need to reflect on the values, consider the core values and the duties and responsibilities. Then weigh the principles, evaluate conflicting principles, identify the actions. So we reflect on the values at stake, consider our options, right? That's our identify the actions. What are the possible solutions here? And this is also to work looking at the client, looking at your patients. What are the possible solutions? Then we make a reasoned decision. We choose and we act. We implement the best agreed upon solution. And finally, we evaluate, how did that go? We assess the outcomes and then we learn. That's the reflective part, is we look at the outcomes and we say, how did that go? And if it went bad, why did it go bad? And what do we need to do next time? And document that. Here's how that case scenario went. Here's what we did. Here's what didn't work. And here's what I, if you're in the position of influencing policy, and I would say that we are all in the position of influencing policy because we should be having team meetings and sharing our experiences with our supervisors and managers and directors. This is where that comes into place. We have tried XYZ with these types of scenarios with patients. This was the outcome. This is what the research evidence-based practice shows. But again, this was our outcome. Here's what we believe we need to do differently next time. So that then the facility or business you work at or company you work for or school can create a policy around that situation. The reflective cycle helps us become more skilled over time. It's a continual process. It's never a one and done. There are common ethical challenges that, for the most part, all of our professions in the healthcare interact with, come across. Dual relationships. Now, what is a dual relationship? This can be where a client asks you to be friends with them on social media. This can be where you are treating a family member. This can be where you're treating your friends' children. These are dual relationships. Now, having dual relationships are not a no-no. However, you need to ethically manage the relationship and provide professional boundaries with the clients. This can look like in your intake information, or when you bring on a client, you can literally put in there the definitions of the dual relationship and the level of expectation. For example, conversations regarding your child's care will not take place outside of the clinical practice. I am honoring HIPAA and your child's privacy, and I will not discuss your child's progress, case, issues, plan of care, intervention, outside of this clinic. What that means is I will not talk to you about your child at a baseball game, right? So there's definitely, if you lay it out and you review this with your client from the beginning, that is managing the professional boundaries. As for friendships on social media, I will tell you that should most definitely, if you are treating someone, should most definitely be no. You should not do that. However, there's not a law that says that. However, if you choose to do that, again, you need to recognize that you have an ethical professional responsibility to monitor what you are posting and how you are engaging with that person on social media. You should also have a social media release in your documentation should your client choose to engage with you on social media, that this is no longer in that safe capsule of information. Now that client is saying, hey, you're my doctor, or hey, you're my occupational therapist, and I'm going to be friends with you on social media. Again, I highly discourage you from friending your clients that you are treating on social media. You can create a professional profile if you choose and have them engage with you there. But to have them engage with you on your personal interaction or personal profiles, I highly discourage you from doing that. Another common ethical challenge that a lot of occupational therapists run into is documentation issues. We need to avoid falsification or exaggeration. This one came up quite a bit in my dissertation study that I completed on moral distress as described by occupational therapists. If you're interested in that, that's on the ProQuest database. It's Hernando 2024. There were many descriptions of facilities billing for group treatment that patients were not in group. There were situations where patients were billed for other types of therapy that were not delivered. And so this type of unethical behavior looks bad upon the whole entire profession. And anytime that happens, a supervisor is pressuring you to bill every time there's something different. One of the participants in my study actually said she felt like she was working for the mafia and you just did it or you were fired. And so that's a real threat. And that's a lot of intimidation. And as sadly as it is, the therapist should still not have falsified documentation. And so, competing priorities is another situation that happens where do I balance autonomy versus the safety and organizational demands? Because another thing that my study revealed was that restrictive policies many times goes against or conflicts with ethical values. And so what's the competing priority there? These things aren't always black and white. And so our job is to stay anchored in the values and apply thoughtful reasoning. So even though supervision and billing integrity present significant ethical challenges in practice, we do have an obligation to go through the same process where we're going to look at the information, we're going to assess what values are in play, we're going to look at all those solutions, create the solutions, then we're going to choose a course of action and see what the result of that action was and could we have done better or not. And again, it's not a one and done thing. It is a process of doing it. The more of us that are going through this process is when you actually see significant changes as a whole. Now, ethical case studies. I want to go through a little bit with this here. Autonomy versus safety. If a client refuses a walker post hip replacement, just imagine that for just a minute. The client has been recently discharged after hip surgery, but they tell you, I'm not going to use this walker. I'm done with it. And you've gone through the whole scenario as to this is what is safe. You've seen this client get in and out of the bathroom, and you just know that this client absolutely needs to use their walker. But this client just says, I don't need that, and I don't want people to see me like that. And so, where does this fall in line? Are you ethically bound to adhere to what's the safest thing for this client? Or is it autonomy? Their choice. Autonomy says that we respect that choice. But beneficence and non-maleficence urges to protect them from falling, right? So there's this conflict that goes within us, and it's a real life challenge. What would you do? I want to give you a minute to just pause for a second. What would you do? Would you go on the side of beneficence and on non-maleficence where you're protecting them from falling? Or would you respect their choice? In this situation, you would respect the client's choice. You've discharged them from hip surgery. They're discharged from care after hip surgery. They're just refusing to use the walker. You respect their choice, and then you document as such. You document your concerns. You've discussed the need for safety with the client. You've discussed the use of the walker. They've used it. They're good with it. You've observed the client unsafe without the walker. It is your clinical recommendation that they use the walker. However, in respecting the patient client's autonomy, they have chosen to not use the walker. Period. They've chosen not to use it. You have stated that. So if, and for some reason they fall, blah, 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 and they come back and say, well, I fell and I didn't have my walker. Well, you chose this. So you have the documentation. Documentation integrity, since we're on documentation. In this scenario, you're asked to record therapy minutes that you didn't actually deliver. This type of scenario, pressuring to document therapy minutes not provided, this tests our commitment to veracity and fidelity. How would you respond to protect your license, your values, and your client's trust? Think about that for a minute. Just think about that for a minute, because this is a very real situation. I shared with you that is what several of the participants in my study revealed to me. So this is very real. So how do you believe you would respond? Would you protect your license and your values and your client? Or would you protect your job and your paycheck? Because you have debts, you have bills, you have a family. I'll give you a minute to think about that. That's tough, isn't it? That's a tough situation, because that is very real. If you refuse you could be fired right away. And then you run the risk of having that employer tell other employers that you didn't follow procedures, right? You have that. It's a very real situation. That actually happened to one of the participants in my study. She did refuse and she was fired. She was in on a work visa. And she was threatened with losing her work visa because she had difficulty finding another job because when she put down the previous employer, that employer reported she did not follow policy. Now, as a business owner, I will tell you policies are written and unwritten, and this was an unwritten policy. So if you are in that situation, would you protect your license, your values, your clients, or your job? Now, ethically, you need to protect the license, your values, and your job. Your client's trust. There should be a refusal to participate in the action requested. It does not have to be a full-on argument. It's simply I respectfully refuse to record therapy minutes that I didn't actually deliver. I have no problem going in and seeing this client and delivering those therapy minutes. However, I am not able to document or bill for minutes that I did not provide. And document that you said that. You don't have to put in a patient's chart. You can keep your own notes that you said that and who you said that to. The second part of that, there is an obligation to report that to the proper department, whether that proper department is your person that's above your manager or supervisor. Perhaps you have a director of rehab. If you don't have a director of rehab, perhaps you have a HR manager, or you have a director of the facility, or by your time clock or in your digital platform, there will be a reporting agency or number. You can use that one. And then if you don't have any of those, you can absolutely report it to your state board. So the first one is to refuse the action, and the second is to report it to the proper department and or authority that you believe is the next one that is appropriate. So again, keep record of what you were asked and by whom, and to whom you reported it. Include the dates and the names of the reporting personnel. If it was an email, the email address. If it was a phone call, the phone number, the date, and if you spoke to anyone specifically, ask for their names. If you're doing it anonymously, you can still ask for their information without having to give your information. Sometimes the ethical challenge isn't internal, but it's structural. So maybe your organization lacks those policies, like I just mentioned, or your manager discourages ethical discussion. Like it's a hush, hush. No, we don't talk about that. Or it's the little eyes that move to the left or to the right, right? We know those looks. In these cases, advocacy becomes key, raising the concern and then suggesting solutions. It is important to lead by example. Many of us know that institutional policies are not created by clinicians. And so we as clinicians are ethically obligated to report any discrepancies in our code of ethics that conflict with those institutional policies. We need to raise that concern and then suggest a solution. It may be just changing a few words. It may be that there is an additional step before a certain policy. There may be another form that is added. But if we are not speaking up or raising the concerns that an institutional policy conflicts with our code of ethics, then we are not acting as ethically sound as we should. An example of this would be around productivity. AOTA does have stipulation on acceptable levels of productivity. And so an institutional policy may state that a therapist must be 100% productive, and that productivity is calculated based on how many minutes are billed and how many minutes the therapist is in the facility or on the clock. And so a concern over that is that in order to meet that 100%, in order to bill for the same number of minutes that you are on the clock, that encourages therapists to document off the clock. That also encourages therapists to act unethical in other ways. And this is also supported in various research. A suggested solution would be that the therapist also has allocation of duty time. In other words, there is billable time and non-billable time. So if you are working with a patient and you are doing billable time, and yet non-billable time, such as you're having to spend 15 minutes getting that patient from the 5th floor to the therapy gym, or you're having to stop your treatment so that the patient can have meds completed or blood sugar levels done or insulin injections, things of that nature. You're coming and going in and out of that patient's room, or you're being pulled into the hallway to have a doctor has pulled you into the hallway to have a discussion with you on a patient, or the social worker has reached out to you, or an equipment vendor has come in because they need to talk to you about so-and-so's order, about their equipment that's been ordered, that's been backed up, any of these things that are non-billable, or even helping a family member decide on which bedside commode on Amazon is going to be beneficial for them. Those are all considered that non-billable time. And so if a solution would be for your facility for you to be able to document non-billable time and billable time so that you can show that every minute you are in the facility, you are in fact productive. However, you have 85% of that time is in billable productivity, and 15% of that time is non-billable productivity. And these are just conversations that we can have, and then lead by example. If your facility says, no, we're not going to do that, then you document as you are, list your true productivity. And then on a separate notebook for yourself, you keep, this is the non-billable time that was there and the billable time that I had. So if you're called in about productivity, you can say, this is my actual billable and non-billable productivity numbers. And that is why my productivity number that you see is 85%, despite the fact that you have a policy that says I have to have 100%. And then you cite the Code of Ethics in AOTA. These scenarios that I've mentioned, they highlight conflicts between autonomy and non-maleficence, veracity and fidelity, and organizational demands versus the client welfare. Now, some of the reporting from AOTA says that we must take into consideration the organizational policies that we work for, the organizational demands. And yes, we must. Ultimately, client welfare is what is going to be your guiding compass. And I know that's going to put several of you in an uncomfortable situation. We have to follow the rules of the law, but then we also have to keep the client there. So if what we're doing, first and foremost, abide by the law of the land where we practice, and then to the best of our ability follows company policy and the client welfare. If the company policy conflicts with Code of Ethics and law of the land, you have an obligation to discuss that and bring it up to your facility. Now, whether they do anything with that or not, that sadly is out of your hands. However, you can document. So if at any time your ethics are called into place, you can say, here is what happened and here is what I did. You must be able to bring that back up, because otherwise it's just going to be, you didn't do anything. That's the biggest ethical dilemma. What did you do? Did you do nothing? Did you question a supervisor? Did you bring it to someone else's attention? Did you voice your concerns? Did you offer solutions? And if you did and nothing took place, then you say nothing took place. And so this is how I interacted with my client. As professionals, as occupational therapists and professionals, we have an obligation to continue our education because things change. The evidence in treatment changes, the rules of the law of the land change, the regulations change, and clients change. Disease changes. Information changes. So we have an obligation to continually educate ourselves and to professionally develop the knowledge base. We must become lifelong learners in ethics, not just ADLs, not just shoulder mobility, not just electrical stimulation, not just physical agents of modalities, not just hip precautions or fall precautions. We must continue to do lifelong learning in ethics. Again, because things change. Ethics evolve with practice and policy and the law. And so if a law changes, we must educate ourselves to that law change. I was surprised to discover that many therapists do not know where to locate their state practice act. That is the rules of that state in how you can practice as an occupational therapist. We know what AOTA says, we know what NBCOT says, but your state practice act are the laws that govern how you practice in a state. If you do not know those or even have it as a close by resource, you are practicing unethically. Many times that practice act gets updated 2 years, 3 years, however many times. You must be reviewing that practice act. Some of the things that have changed in the course of my professional OT tenure in the state that I practice in, which is Texas, So many things have changed. The rules of supervising an occupational therapy assistant has changed. The who can refer someone to occupational therapy, those rules have changed. And also, when as a practitioner, do I need to get an evaluation before I treat? Now, if I wasn't staying abreast of those Practice Act, I would not know, and therefore I would not be practicing ethically. Lifelong learning is part of professional responsibility. Now, this one's a little bit of a soft spot for me because I view professional development very strongly in that I don't believe that you should take the same shoulder course over and over again. I believe that as a professional, you should be challenging yourself and not taking the lowest level of courses just so I can check the box. I believe that we have an obligation to our patients and our clients that we serve to seek out high quality professional development courses. And I say this because if I'm having heart conditions, I don't want to see the cardiologist who's checking the box on their CEUs. I want the cardiologist who's seeking the most advanced and most current evidence-based practices to treat me. So that is why we need to look at lifelong learning as a professional responsibility and ethically look at what are we taking as professional development courses and are they truly benefiting our clients that we're serving and continuing our education, or are the courses we're taking just to check the box and just a regurgitation of what we already know? With regard to ethics, NBCOT encourages 1 hour of continuing education minimum on ethics. And many states have added ethics courses as a requirement to their continuing education requirements. It's not in every state, but many states have. And so lifelong learning and ethics is a professional responsibility to protect, again, you as a practitioner, the profession in which we work, believe it or not, the organizations in which we're employed, and the patients and communities in which we serve. Now, there's some key takeaways here today. Ethics, they guide clinical integrity and protect the clients. The AOTA Code of Ethics should be used as a compass. Now, I understand that you need to become an AOTA member many times to gain access to the Code of Ethics. I understand that. If you choose not to be an AOTA member, seek out one of your colleagues that is an AOTA member and request a copy. Ask if you can review their copy. Ask if you can buy one from them. But utilizing the Code of Ethics and referring to it in your workplace or when you're working or talking to your colleagues or even in the other healthcare, with the other healthcare professionals, that's going to actually set you above because they're going to say, wow, that person knows the Code of Ethics. Wow. Many times we are challenged to act unethically and we feel that it's unethical, but we don't have the evidence, the Code of Ethics, to back us up. We don't have a sound awareness and knowledge of what it is to back us up in our conversations and to refute what we're being asked to do if it's unethical. We need to document ethically and act transparently. Think about that for a second. Document ethically. I know many times that we have computer systems that automatically with AI will just, complete your sentence. If that sentence does not match what you did, override the system. They all have it where you can write in, where you can document what you actually did. Just because your facility has auto-populated documentation does not mean you have to utilize the auto-imported documentation. There should be on all of them a narrative box in which you can type it in. Does that sometimes take a little bit more time? Yes. Is AI getting better with it? Yes. But do not sign your note if what is in that note is not reflective of what you ethically feel you completed in the treatment session or interaction with the patient. Act transparently. If AI completed your notes, know that AI completed your notes. And if they ask, this was completed by AI. You need to reflect on your values regularly. And most importantly, to stay informed by CEUs and peer discussion. One of the things in my research study that was shared multiple times by several of the participants is that having the opportunity to discuss with peers the ethical dilemmas that they were dealing with enabled them to come up with peer-directed solutions, and they felt empowered to go back and implement changes in their department and facilities. So it's important as a professional and to minimize your risk for moral and ethical distress to stay informed with CEUs and peer discussion. Ethical dilemmas occur every single day, and ethical distress and moral distress occur when you know the ethical course of action to take, but yet you cannot do so because of some constraint in your work environment. That constraint can be such simple as those policies that we talked about, or an overbearing supervisor that you feel threatened by. Those are constraints. You know what needs to be done ethically, and yet you do not feel you are able to do that. So there must be another solution to alleviate that distress so that you feel there is something you can do. And sometimes that comes about by having peer discussion with other people in your department, sometimes even at state association meetup groups, other therapists, without disclosing any protective information of your clients or even policies in your or where you work, right? So sometimes there's those stipulations, but being able to have peer discussions, I do know sometimes it can be many of the occupational therapy groups on social media. You can post anonymously to get interaction. In fact, that was another thing that many of the participants in my study on moral distress disclosed, was that they would go in and post the scenario that they were dealing with as an anonymous poster, and they were able to gain suggested solutions. And so that is a great way that you can assess the dilemma that you have, gain some peer discussion, and then feel empowered so that you can go in and make the change that needs to be changed. Or like we discussed, report the incident, have the discussion, make the solution. And sometimes you can't do anything else other than those, and that's what you document. So today we explored how ethics shows up in everyday decisions and how the tools like the AOTA Code of Ethics can guide us. And I encourage you to keep these principles close by. You should use them. Reflect often. Ethical excellence is a journey. It's not a destination. It's a long road. And so keeping the principles close by will help you continue to stay on the ethical path. Before I end this, I want to tell you that I am grateful to you for taking this course, number one. But number two, to continue to hold yourself to a higher level of standard. It's not easy to be in the industry that we're in. It's not easy to work in the systems in which we have to work. It's not easy to work with all of the constraints that we feel that we have. But as a profession, if we do not adhere to our ethics, are we really a profession? Can we count ourselves as professionals? I don't believe so. And so by you taking this course, whether your state made it mandatory or not, you're holding yourself to a higher level of standard, and you are representing the profession ethically by continuing your education in ethics. Now, as I wrap this up, a little bit of housekeeping. You've taken this course with me here. You've listened to the recording. When you purchased the course, you were given an email that has a survey, which is the course instructor and evaluation sheet along with the quiz. Those need to be completed before your certificate can be sent to you. Your feedback on this course matters. This is my first course of this type that I've put together. I have another course that's out there that is specifically over the results of my study, moral distress, as described by occupational therapists. But any feedback that you put on there does help me improve this course. And so if you'll complete that portion, you have to complete it on some level. You have to complete it because if I don't get it, then I can't give you this to you. But if you'll answer that, that would be very helpful. And then once you complete that and you pass the quiz, you will receive your certificate via email. I strive very much so to turn that certificate around to you as soon as I receive your quiz and score it. However, I do request that you give me 24 hours because if you're doing this at 3 o'clock in the morning, it's not going to be an immediate turnaround. So if you will please just give me 24 hours turnaround, that would be great. Again, most of the time it's turned around rather quickly. And that's it. So thank you so much for being here and listening to me. And again, your commitment to ethical excellence. If you have any questions or wish to have any other discussions, if there's something that you want to discuss that's happening in your place, I'm open to that. And you can email me at the contact information in the email that you were sent. So thank you so much.